Hello, my name is J.D. Corl. I'm an interventional cardiologist from the Christ Hospital in Cincinnati, Ohio. I'm here at VIVA 2024 to discuss the Javelin IVL catheter from Shockwave. Calcium is very common in peripheral artery disease, especially in patients with advanced peripheral artery disease, such as patients with critical ischemia. These patients often have multi-level disease and thick, dense calcium that can extend into the medial layer. Current treatment technologies do not adequately treat medial calcium. Treatments such as balloon angioplasty and atherectomy. Lithotripsy does address medial calcification and modify that calcium. We know that balloon-based lithotripsy is very safe with low rates of dissection, perforations, and embolisms. But crossing these lesions can be a challenge with traditional therapies such as balloon angioplasties and atherectomy, as well as balloon-based lithotripsy. The Javelin catheter is a novel, non-balloon-based lithotripsy catheter with a forward-shifted emitter to assist in cracking calcium in front of the tip and advancing the catheter through that calcified stenosis. The tip of the catheter has an emitter which is 3 millimeters from the tip. It can extend the energy profile beyond the tip to help modify that calcium and assist in crossing. You'll see in this video the standard balloon-based lithotripsy catheter. The distal emitter is not close enough to the tip to affect the calcium to allow crossing of that device. You can see the Javelin catheter with that forward-shifted emitter can modify the calcium even out in front of the tip to assist in crossing. Here's the anatomy of the catheter. You can see it's a 150 centimeter shaft, a 0.014 platform. It's an over-the-wire system. The crossing profile is 1.5 millimeters. The distal 50 centimeters of the shaft is hydrophilic, and the distal 25 centimeters is flexible. This device has 120 pulses, 12 cycles of 10 pulses each, with a 10-second break between cycles. You can see the distal window. This is, again, a non-balloon-based catheter. The distal window, which saline is flushed through. You can see the inlet port and the outlet port, which allows you to flush the saline through to allow coupling of the energy from the emitter to get into the calcified plaque. We know from our experience that the balloon-based Shockwave lithotripsy is safe and effective in modifying plaque. We've also found that the Javelin catheter has the same safety profile, and also, in addition to crossing, does provide modification of the plaque as the catheter crosses through the calcified plaque. So you get assistance in crossing as well as modification of the plaque and the dense calcium. We're going to go through a few cases here. This is a 79-year-old male with a history of hypertension, tobacco use, coronary disease, and renal insufficiency. He's got a severe stenosis in a distal right SFA. The lesion length is 116.73 millimeters, and the calcification was severe. You can see the follow-up images. The second panel over from the left is the post-Javelin images prior to any balloon angioplasty, and you can see the significant lumen gain just with the Javelin catheter, followed by the third panel, which is post-dilatation, and your final images following drug-coated balloon angioplasty with a 6x150 balloon with an excellent result. Here's another case example, a 51-year-old male with the usual risk factors and past medical history: hypertension, diabetes, coronary disease, renal insufficiency, atrial fibrillation. Patient has critical ischemia of the left foot. Here you see a left posterior tibial artery with a severe, heavily calcified stenosis, another chronic total occlusion, which is common in CLI patients. You can see in the left panel the pre-images. The middle panel is post-Javelin with significant lumen gain. And then the final images following balloon angioplasty with a 3x120 balloon with an excellent result. Here's our third case example, 85-year-old female with non-healing ulcer left foot, past medical history of hypertension, hyperlipidemia, tobacco, diabetes, coronary disease, and atrial fibrillation. Got a chronic total occlusion of the left anterior tibial artery. Lesion length is 92 millimeters with severe calcification. Again, you can see that middle panel post-Javelin therapy with significant lumen gain. Again, this is prior to any balloon angioplasty. And then the final images on the right following balloon angioplasty with a 2.5 by 100 balloon with an excellent result and significant lumen gain. In my early experience doing cases commercially through the LMR as well as cases in the forward IDE trial, I have found the device to be easy to use, safe, just like other lithotripsy technologies. And I found the same results with luminal gain following treatment with just a Javelin catheter. Significant luminal gain before post-dilatation is needed. And in the vast majority of cases, additional lithotripsy catheters are not required to further modify the calcified plaque.